into clinical and demographic perspectives of occupational eye injuries by Dr. Subhatra.
Demographic profile, perspectives of occupational eye injuries. Occupational eye injuries are defined as the injuries occurring as a direct result of work or conditions at the workplace. It is the leading cause of ocular trauma worldwide and constitutes to about 22% of the total ocular trauma in India. The toll of these injuries go beyond pain and visual limitation. The reassuring fact is that most of these eye injuries are preventable. Occupations and type of activity at risk for injury vary from region to region and needs to be identified in order to plan preventive strategies. So this study was done to analyze the demographic and clinical characteristics of occupational eye injuries. It was a prospective study of 1 year duration, and all patients with occupational eye injuries presenting during the study period were included. Those with coexisting ocular pathology were excluded. So detailed history was taken, comprehensive ophthalmic examination was done, and standard care of treatment was provided to all patients. And the statistical analysis was done using the following tools. A total of 316 patients were included in the study, and majority of them were men. This was similar to the results of most other studies and can be explained by the fact that traditionally the men are more frequently employed in high-risk occupations as compared to women. And majority of them were young, with about 58.9% of the patients in the age group of 21 to 30 years, thereby suggesting that inadequate work experience may have a role to play. However, other studies from India suggest that occupational eye trauma is more common in older age group, contradicting our results. So injury was more common in unorganized sector, with arc welding being the most common occupation at risk. Previous history of eye injury at workplace was noted in 65.8% of the patients. This result was higher than the results of the other studies, which ranged from 4 to 34%. And all these patients were engaged in welding or grinding work. This goes to say that recurrent eye injuries are more common in unorganized sector, like small fabrication enterprises, where safety training is not provided to the patients. And eye injuries are not acknowledged enough by the workers or the employers to promote adoption of safety measures. Unilateral eye injuries were more common than bilateral, and most of the patients presented to the hospital on the same day as the injury. And corneal foreign body was the most common type of eye injury seen, and closed globe injury was more common than open globe injury. However, open globe injury was associated with poor visual prognosis, and it was common among carpenters. Most of these eye injuries can be prevented by use of appropriate protective eye gear. In our study, about 95.25% of the patients did not use any safety devices at the time of injury. Interestingly, about 61.79% of these patients had access to these safety devices. The reason for not using them was inability to see clearly through it. Some forgot to use, and some without any reason. Studies have found that though workers had knowledge and access to the safety devices, they did not use it due to ill fit, poor visibility, and the discomfort caused. A small percentage of patients had injury despite wearing these safety devices. This questions the efficacy of these safety devices. Hence, there is a need for provision of effective, user-friendly protective devices with a good fit and good visibility. Most of them had good final visual acuity. Permanent visual impairment was noted in about 20.8% of the patients. The limitation of our study is that we did not study the employment pattern of the patients as permanent and temporary, and since it was a hospital-based study, the results may not reflect the actual epidemiology. Yet, this study can serve as a baseline data for further studies to generate input for policymakers. To conclude, this study provides insights into the clinical and demographic characteristics of occupational eye injuries. These injuries can be prevented by use of appropriate eye gear and safety training. While planning preventive strategies, Priority should be given to workers involved in metalwork, agriculture and carpentry, where increased frequency and poor visual prognosis is seen, and specific interventional programs should be planned to prevent recurrent eye injuries. Thank you.
Thank you, Subhatra. What was the inclusion criteria for these patients study?
All the patients with the injury at the workplace were included in the study during the study period.
Because that will be a vast thing, and it will be haphazard. You cannot classify all types of injury in this type of thing.
Yes,
So
but
it should be specific, whether it is a farm injury, or it is a chemical injury, or this is due to some.
ma'am, we have put, we included all the workers and then we classified whether it was agriculture related or metal work related or
No, what I want to say, you cannot compare the different type injury with each other.
yes.
So
Yeah, there is a
study
wide
should be-
variation, yes, I agree
Study
that.
should be having a strict
Okay,
pattern.
yes.
Thank you.
जैसे इतना कॉमन है बट एग्रीकल्चर इंजरी बहुत कॉमन है
हाँ.
देश में
Yes.
एग्रीकल्चरल फार्मर्स की इंजरी बहुत कॉमन
Yeah, हमारे स्टडी में वो सेकेंड नंबर में था, yes.
You said that you had a younger cohort of patients. So what was the occupation of the patients who were there in the other studies, who were of older age group?
It was the results. Other results were similar, ma'am. Cornell, in like other Indian study from north and northeast, two studies are there, and the Cornell foreign body welders were the most common. But they have also found that construction workers are also an important occupation where eye injuries are common, which we did not find in our study.
Good morning, all. Today I am going to speak about analyzing the distribution of blindness among individuals applying for visual disability certificate. Now, conflicts of interest, financial or otherwise regarding this paper. Visual impairment is a major health problem. According to WHO, around 180 million people globally suffer from visual impairments, with about 45 million of them being completely blind. India faces a severe challenge with approximately 8.9 million blind individuals, representing nearly 20% of the global blind population. As of 2024, India could reduce the prevalence of blindness to 0.36% of the total population with the help of National Program for Control of Blindness and Visual Impairment. The main aim of my study is to analyze the major cause of vision loss, visual disability, sex preponderance, age distribution pattern, and to categorize and assess the percentage of visual disability. Materials and methods. A cross-sectional observational study was conducted in the Department of Ophthalmology, SIMS, on 100 patients seeking visual disability certificate or a period of 12 months. All subjects will undergo a detailed ophthalmic assessment, including visual acuity, strict retinoscope, anterior segment examination, A-scan biometric, keratometry, IOP, and fundus examination. And percentage of disability was calculated based on this. Patients of any age group attending ophthalmology OPD of a tertiary care center for visual disability certificates are included in our study. Patients with less than 40% disabilities are excluded from the study. Informed consent was obtained from all subjects. Statistical method, the data was collected and will be entered in Microsoft Excel. Descriptive statistics like mean percentage will be applied for quantitative data. As per the study, our results were, out of 100 individuals, majority 63% of them were males and 37% of them were females. And age distribution, majority of them falls under the category of 21 to 30 years, followed by 31 to 40 years, and then followed by 41 to 50 years. And based on the number of individuals in each category, majority of them falls under 40% of visual disabilities, followed by 60%, and then followed by 80%. And based on the causes, majority of our people who had come for visual disability certificate have congenital anomalies, followed by refractive errors and retinitis pigmentosa. And age groups is majority of them from 1 year to 30 years of age, majority of them were having congenital anomalies, and from 31 to 40 years, majority of them having retinitis pigmentosa, and above 50 years, majority of them having diabetic retinopathy. And discussion in our study, a male preponderance was observed, which may be attributed to the certification system being institution-based, making it difficult for females to access due to various social barriers. And this findings aligns with the studies conducted by Ghosh et al. And Joshi et al. But the 58th round survey of NSSO survey was contradicting our study. And we also found that younger patients formed a significant majority compared to older individuals, with most participants being between 21 and 30 years of age. This suggests that certification is often pursued for educational, employment, and transportation benefits, which are more likely to be relevant to younger individuals than the elderly. Ghosh et al. Reported similar findings. In our study, congenital malformations were the leading cause of visual disability, followed by refractive errors and retinitis pigmentosa, consistent with the result of studies of Karim Sab and Ghosh et al. Limitation: the exact prevalence of visual disability cannot be obtained as the registration is voluntary. The rates could not be calculated as we had no specific population denominator, and it's a hospital-based survey. Since it is not a community-based survey, it may not give the true reflection of the distribution of various causes of visual disability. And conclusion, the results indicate a high prevalence of congenital eye disease and retinitis pigmentosa, highlighting the importance of genetic counseling. With better health education, eye care, and compulsory periodic school eye screening, preventable cause of blindness can be reduced, such as refractive errors. Mandatory screening for conditions like ROP, diabetic retinopathy, and glaucoma should be implemented. Reducing eye trauma can significantly lower the risk of visual disability from corneal scarring and infection. Additionally, improving the quality of life for blind individuals require well-maintained, accessible, affordable, and sustainable rehabilitation services. These are my references. Thank you.
Thank you, Dr. Aruna. Just tell me, what was the incidence of blindness in your cases regarding the glaucoma, injuries, and any other condition, apart from the retinitis pigmentosa and diabetic retinopathy?
Glaucoma, 5% of the patients.
Only? Corneal blindness kitna tha?
11, ma'am. Ma'am, those who are coming for certificate, based on that only, we are taken our samples, not on the OPD basis, ma'am. Those who are come just to apply the visual disability certificate.
In your center, these patients are not coming?
Glaucoma patients are not much coming, so that elderly populations, majority of them, they may not be taken to hospitals by their relatives, maybe. Maybe that is why we are not.
के लिए बड़ा वो आते हैं ना जिनको उससे फायदा हो गवर्नमेंट की जॉब में उसमें तो these are generally though mostly congenital and विजुअल डिसेबिलिटी के सर्टिफिकेट लेने बहुत लोग आते हैं बट मोस्टली दोज हु वांट दैट 33% जो मिलता है जो गवर्नमेंट में फॉर द डिसेबल्ड उसका फ़ायदा उठाने के लिए कई बार हम थोड़ा सा 2 लाइन कम करके झूठा ही बना देते हैं तो टू हेल्प पीपल वी डू दैट आल्सो
Okay.
You have rehabilitation services also for these patients?
Low vision, it's like spectacle service we are providing from our centers, ma'am. No others. No, ma'am.
Okay, thank you.
Thank you.
Now we would invite the next speaker, Dr. Siddharth Mishra. Is he there? Dr. Ananya Hota? Dr. Ashwini? Yeah. Dr. Ashwini will be presenting on our experience with hard cataracts in the Cataract and Eye Care Camp of Andaman Islands.
Thank you. Good morning, everyone. I'm Dr. Ashwini Mehra, Chief Medical Officer from Safdarjung, New Delhi. It is a privilege for me to present our experience with hard cataract and eye camp of Andaman Islands. No financial disclosure. Why was this camp was needed? This camp was needed because there's a scarcity of government eye surgeon and facilities from the last 5 years. And it's a larger tribal population with lower socioeconomic strata and more of smaller islands. And assessing these patients to the mainland was very difficult for them, and also challenging, and also referral was very difficult. And we also found with higher grades of cataract and ocular comorbidities. So the Government of India, the Ministry of Health, organized this camp in JB Bant, Port Blair Hospital, and from January to February 2024. There were 3 teams in it. I was in the second team with a team of 3 surgeons, and we operated nearly about 180 patients. And we encountered mainly with the hard cataract. Both SICS and phacoemulsification surgery was done. So our study was to evaluate the outcomes of SICS versus phaco in hard cataract of Andaman population. So that it is a retrospective descriptional study, and the sample size of 160 patients was included in my data. 2 groups divided into SICS and phaco. In SICS, we have done 95 surgeries, and phacoemulsification 65 surgeries, based on the surgeon preference. Now, the inclusion criteria, mainly the cataract of grade NS3 and more, according to Locke's classification, but we also excluded the diseases of glaucoma and retinal diseases around 20. So we have operated only 160 patients, which is included in my study. Pre-op workup was done, fundus examination, B scan, blood sugars, urine. B scan is very important for me since I'm a retinal surgeon also. So whenever I see hard cataract, I do B scan to rule out vitreous hemorrhage, diabetic retinopathy, or if is there any RD. So the parameters analyzed were demography, grade of cataract, and the vision preoperative day 1, day 7, and also the cornea clarity. The results, the males were more in both the groups, SICS and phaco. And the mean age group was 65.3 years, ranging from 50 to 75 years of age. The grade of cataract both in SICS and phaco was NS5 grade and 52% and 51% in phaco. So the preoperative vision in both the group SICS and phaco, it was only hand movement close to the face to counting finger 3 meters. So this is my small clip of my surgery, which I want to always prefer to go for SICS whenever I see the challenging hard cataracts, especially when you don't have retinal infrastructure, no retinal surgeon, and for this place also they have to go to Chennai, and it takes around 2 days to go by ship. So it is very important to go for SICS if you don't have backup for retina surgeries. So the challenges which we have faced are very important. Some of them are poorly dilating pupils, there was journal of weakness with phacodonosis, there was a pseudoexfoliation, mature cataracts, and also in some cases they were subluxated. So this was one of the cases, a 70-year-old man, it was total hard cataract and was anteriorly dislocated in the pupillary margins. So I decided to take it out and do the SICS, and luckily I was having the same power of iris flawless, and I implanted into it, and the vision came out to be 6/36 on day 7. The post-operative vision, which I found out in SICS and phaco comparatively of 6/12 and better, was improved in SICS from 75 to 92%. As comparatively in phaco, it is improved from day 1 to day 7 from 40% to 68%. And the clarity of cornea was much more better in SICS compared to the phaco. So other postoperative complication was just descendant memory detection phaco, and some rents were there, but we placed the IOL in the sulcus. We are lucky enough there was no nucleus drop and no lens drop. So we just found out that these kind of mature category found out every day we're taking pictures, and I found out the SICS group has better clarity, post-operative, better vision. Since I feel that younger surgeons are facing difficulties in doing SICS because of inadequate training. I just conclude that SICS is a safer, we all know, it's a big thing. It's a safer, cost-effective surgery for hard cataract and eye camps where long-term follow-ups are not possible. And it should be continue to be a part of resident training for handling such kind of scenarios. Thanking you. This is my clip of paper we're taken during that camp. And it's just a question mark also for all of the doctors. There are so many hard cataract in some places, and there are no doctors. Thank you.
Very good, Dr. Ashwini. Your presentation is really good.
Thank you.
And it is the need of the day.
Thank you.
How did you reach the sample size of 160? Was any sample size calculation done for the study?
The total we have 160, phaco and SICS.
Okay.
But we have excluded 20 patients because they were having other complications. So we decided only to keep that one in order so that we can compare easily the visual acuity, because we can't compare if you have other complications. You can't compare the visual acuity with SICS and phaco.
And what about the astigmatism? Was
With
there
that
any
we can't
difference?
do. We have just follow-up done up till the 7th day. Na? Then
Okay.
Thank you.
Thank you.
Andaman like place, you know, it is so difficult. We have gone there many times, like as a training of trainers. We went to train their doctors or whoever there. But you know, even doctors run away from there.
Same problem was there. There was one doctor and she ran away. There was no doctor for the last 5
Only
years.
thing you-
No surgery. So the government of I was the senior most surgeon. I went with my junior.
Great.
Thank you.
ओपन हॉस्पिटल में तुम जब कमरे हैं वहाँ तुम सोते हो
हाँ very
समुद्र के
difficult.
किनारे जिंदगी
ये
में
सब मैंने सीनरीज डाली हैं इसमें.
ग्रेट वेरी सुंदर प्लेस बहुत ही ब्यूटीफुल जगह सबको जाना चाहिए
But working is difficult there. Tribals है ना, they are very
Dr. Sukhdeep is there? Yeah. Dr. Sukhdeep will be presenting on comparative analysis of quality of life in ophthalmic patients and healthy participants.
A very good morning. So my presentation is about comparing the quality of life in patients using prosthetic eyes, that is ophthalmic patients in one eye, and compare them with healthy patients. So what is quality of life? WHO defines quality of life as the individual's perception in the context of his cultural and value systems and in relation to his goals, expectations, standards, and concerns. So the study tool that is usually used now and what we used was WHO Breath. That is a brief version of the WHO Quality of Life Survey. It analyzes the quality of life in 4 domains: the physical, the psychological, social relationships, and environment. The questionnaire is on a Likert scale of 1 to 5, and the scores are then transformed onto a linear scale of 0 to 100, with higher scores indicating higher quality of life. The prosthetic eye used, it can be something that is customized, that is a custom fit prosthesis, or that is already available, which is also known as stock shell commonly. The study design, it was a cross-sectional study. We used WHO BREF for analyzing. We had 66 participants using the prosthetic eye, 54 controls. The controls were family or friends of the patient. So thus, we tried to ensure that the cultural and value systems and the socioeconomic strata that they belong to have a common feature. The statistical analysis that we used were one-way ANOVA, linear regression, and Pearson coefficient. So these are the causes of loss of eye in the study population. The maximum patients that we know were the injury patients. This is the analysis of the male and female ratio in the prosthetic eye patient and in the control patient. We saw a lot more patients who were married in the control population and unmarried in the prosthetic eye. The patients who were using prosthetic eye, almost 90% of patients were happy with their appearance. This was irrespective of the fact that only 63% patients were using a customized prosthesis and 31% were using only a stock shell. The age, we had maximum patients in the age of 25 to 50 years. Education status, maximum patients had a good education status. Regarding our results, we noticed that the quality of life was better in the study population in younger patients and in the social and environmental health in patients with formal education. There was no significance with the gender or the cause of loss of eye. We did notice a negative correlation between the time of loss of eye and the quality of life. In the control group, we did not notice any relationship to gender, marital status, or education, but we did see that the younger patients had better quality of life in respect to social relationships. When we compared both the groups, there was no statistical significance between 2, 3, and 4 domain, but in the first domain, younger patients performed better. So the results, we had no significant difference between the quality of life between the 2 genders. That is, the females had an equivalent quality of life in comparison to the males. This is in contradiction to the other studies which have been published which show an increased rate of depression in female population. We saw a better quality of life in the younger participants, and this is again similar to some studies which say younger populations do better, and in some studies they have said that older patients are not that bothered with their appearance, so they do better with the quality of life. And we saw a higher score of quality of life in married participants, which is similar to other studies. So what did we see? We saw that there was a comparable quality of life in patients who were using prosthetic eye and their control patients, and this could be attributable to the aesthetic benefits of the ocular prosthesis, the reduced psychosocial burden because of the better appearance, and improved self-esteem and self-confidence. These are my references. And to conclude, the ocular prosthesis just not offers a cosmetic rehabilitation, but is also important in the psychosocial rehabilitation. And we're really happy when our eyes are happy, so we should try to make the patients happy.
Nice presentation.
Which place it was? Which institution you did this?
So this is done in Arvind Hospital, Madurai.
This is a nice presentation.
Thank you, ma'am.
But tell me one thing. What about the girls who were unmarried? They were happy?
We did not do this correlation between the sex and the unmarried. We did between the married and the unmarried and the male and female. As such, this subset of unmarried and females, I look into it, ma'am. We did not do it, ma'am.
Married males तो दुखी रहते
सर हमारी स्टडी में बेटर थे. Thank you.
Dr. Navid will be presenting on visual assessment of UP State Road Transport Corporation bus drivers during Road Safety Week 2024.
So my topic is visual assessment of UP State Road Transport Corporation bus driver during the Road Safety Week. Road Safety Week is a paramount. The visual health of the driver is crucial factor in preventing the accident and ensuring the well-being of both drivers and passengers. So the UP State has undertaken a comprehensive initiative to assess the visual acuity and color vision of its bus driver during the Road Safety Week. So the aim of my study to assess the visual acuity and color vision of the bus driver and to conduct the comprehensive vision test to determine the visual acuity and color vision of the bus driver and identify the common eye conditions such as cataract, refractive error, and other conditions like color blindness, and to promote the awareness among the bus driver about the importance of regular eye checkup for Road Safety Week, and recommend and implement the necessary intervention including the corrective eye wear and medical treatment for drivers with visual impairment. This is a cross-sectional study conducted between the 11th January to 17th January during the Road Safety Week on total 143 drivers at Sohrab Gate and Vaisali bus stand Meerut, and the comprehensive eye examination and visual assessment using the standard visual acuity chart and Ishihara chart. So all drivers employed in the UP State Road Transport Corporation who are willing to provide informed consent to participate in the study are included, and the drivers with previous eye surgery and ongoing eye treatment which interfere with study result were excluded. Individuals with medical condition that could affect their vision temporarily also excluded. So the maximum number of the driver belong to the age group of 31 to 40 years, followed by 21 to 30 year, and 41 to 50, and 51 to 60. So maximum number of driver poses the visual acuity 6/6 to 6/12, followed by 6/18 to 6/24. And the maximum number 142 driver had the normal color vision, and one driver was partially colorblind. The majority number of drivers have excellent or near normal visual acuity 6/6 to 6/12, and a small percentage showed decreased visual acuity which could affect the driving safety. and color vision impairment is rare, affecting only 0.7% of the driver. So the largest age group is 31 to 40 year, followed by 21 to 30 year, indicating the bulk of driver are relatively young. And the 92.7% of the bus driver meet the visual standard that indicate the current government policies are effective, that ensure the necessary visual capability for safe driving and contribute to overall public transportation safety. The visual equity is a crucial factor in driving. Clear vision is essential for identifying the hazards to ensure the quick response to traffic signals and signs. 99.3% of the driver have normal color vision, which reduce the risk of accident due to the color misinterpretation. There is always a room for continuous improvement, so we implement more robust visual health programs and enhance the driver education on eye care and regular visual assessment for early detection of issues. 7.3% of drivers do not meet the visual standard, and 0.7% are partially colorblind, who are concerned for public safety, require ongoing visual assessment, and require interventions and resources like corrective eyewear and medical evaluation and alternative duty without driving. Thank you.
Doctor, you have taken these patients only the visual acuity and color vision.
Yes.
What about the field of vision, only the confrontation?
So
is it not important?
Yes, I'm important.
So we should check also. Yes. What about the fundus examination? Because number was not so much. At least you should see the disc for any evidence of glaucoma or the macula. And then you should assess the systemic disease also, whether a patient is diabetic or hypertensive. Because these drivers are always in tension.
Yes, ma'am.
Stress. So they may have the hypertension also.
Yeah.
So this will not be sufficient. You can add these things also.
Okay, thank you. चलता नहीं सर, ये 3 monthly 4 monthly 6 monthly ये चलता रहता है सर जी.
And डॉक्टर साहब जो कह रही है वो कंसल्टेशन वाला फील्ड भी बहुत
जी.
Because I know the drivers who could not really see on sites in UP only, because he had glaucoma but vision was 6/9.
Okay, sir, thank you. Sir.
For the person who was color vision defective, did you do anything? Did you report that because he will be a hazard?
उसको सर मैम उसको ड्राइविंग से शिफ्ट करके डेस्क जॉब पे लगा दिए गए, और एक ही ड्राइवर मिला था हमको, तो उसको हमने ड्राइविंग से हटवा के उसको डेस्क जॉब दिलवा दी थी.
Thank you.
For your general knowledge to everyone, color vision is not considered anything in the European countries for drivers, because all drivers can see the red and green signals with a lantern chart. We do only Ishara chart, so many people will fail. In fact, partially blind, you know that partially colorblind 4% in males and 0.3% in females. So at least Europe में तो अभी मैंने भी इस देश में करा दिया है कि विजन के लिए, उसकी ड्राइविंग के लिए कलर विजन इज नॉट ए, इफ दे हैव गॉट द लेंटन वाला टेस्ट पे बड़े लाल देख लेते हैं, बड़ा रेड देख लेते हैं, फिट. सो ड्राइविंग एंड आई टोल्ड यू दैट यूरोप में ड्राइविंग के लिए कोई कलर विजन नहीं करता.
Lantern test is not available usually at all the centers.
Oh, yes.
Okay, thank you. We'll move on to the next speaker. Is Dr. Dinesh Verma there? Dr. Pradna Rao? Yeah. She'll be presenting on assessing awareness on posterior segment diseases and acceptance of teleophthalmology in rural areas.
I request if the laptop can be kept at the podium because I broke my spectacles. केवल छोटी है सर.
यहीं से बेटा बैठ के बोलते हैं.
हाँ यस बढ़िया.
सीधा भैया.
नहीं आप यहाँ कर लीजिए, मैं देता हूँ. ये बैठ कर लीजिए.
यहीं से बैठ के बोलते हैं.
नहीं लैपटॉप. अच्छा. I'll start, ma. Good morning, everybody. So let me take you through this wonderful journey of a study that we conducted named Assessing Awareness on Posterior Segment Diseases and Acceptance of Teleophthalmology in the Rural Areas, mainly the District Blindness Control Scheme camps that DBCS camps that the government conducts. So we've conducted the study on those camp patients. So what is community ophthalmology? It is nothing but the health management approach in preventing eye diseases and reducing morbidity. It comprises of a comprehensive evaluation that the patient have to undergo. That is, in terms of preventive, curative, promotive, and rehabilitative activities. It is also referred to as the community-based eye care services. However, they share a common goal, that is, improving ocular health of the community with the active community participation. Ocular health, as we all know, is a critical for overall well-being of an individual, particularly in the rural areas wherein the access to eye care is often limited. In a study that was conducted by Sharma et al., around 82% of the respondents were willing to participate in teleophthalmology or teleconsultation. So in the picture here, what do we see? On the left-hand side, we have rural areas, and on the right-hand side, it shows the big cities. So this, with the help of this one instrument, that is the fundus on phone, the gap between the two areas can be bridged by such a simple instrument which can be used at the DBCS campsite. So we all know that India has a social burden of tuberculosis. Having said that, we should not neglect the non-communicable diseases, that is diabetic retinopathy or hypertension. As per the national survey which was conducted between 2015 to 2019 by Praveen Vashisht et al., he found that diabetic retinopathy among the study subjects with diabetes was around 16.9%, with sight-threatening diabetic retinopathy accounting to about 3.6%, and mild retinopathy cases accounted to about 11.8%. So another posterior segment pathology being glaucoma. So how do we communicate this to the camp patients? We just say that, sir or ma'am, the pressure within your eye is on the higher side. In Hindi we would say, आपके आँखों का pressure जो है वो थोड़ा ज़्यादा है. And in Kannada we would say, निम कण्ಣಿಗೆ pressure ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಇದೆ. So that is how we explain it to the camp patients. Having said that, as an ophthalmologist, a glaucoma triad would comprise of either a normal or a raised IOP with the optic nerve head changes in the form of optic neuropathy and the corresponding visual field defect. So a normal individual would see the first picture, whereas a glaucomatic individual would have a tunnel vision or the tubular vision. One of the most important risk factors for the development of glaucoma is age more than or equal to 40 years. And prevalence ranges between 2.7 to 4.3% among the Indians. This was again published in the Indian Journal of Ophthalmology. And glaucoma, as we know, is the second most leading cause of irreversible blindness. And that is the reason why we need to emphasize on early diagnosis and management of such a condition. Here our study, again it aimed at awareness of the posterior segment diseases and acceptance of teleophthalmology. And the primary focus of the study was screening of the posterior segment diseases in the camp patients. Our sample size accounted to about 1,000 patients, 1,000 to 1,209 patients is what we have collected so far. And it also comprised of a questionnaire which was standardized in order to gauge their knowledge levels concerning the posterior segment diseases as well as their attitude towards the teleophthalmology. This was the study protocol. And the study design, it is a cross-sectional study design with sample size of 1,209. Again, the results were analyzed at the Department of Ophthalmology in Ramaya Medical College, Bangalore. Statistics was done using SPSS software version 29. And that image shows the screening of the camp patient by the resident doctor. The gender distribution, most of the frequency was that females were the dominant in this the study group, and again educational level ranged from non-literate to graduate, and in our study it was seen that primary school individuals were on the higher side. Again, diabetic and non-diabetic population, so diabetic accounted for about 18.8%, and when compared glaucomatic and non-glaucomatic, glaucomatic comprised of about 0.3%. So the results again, when we look at the awareness of various posterior segment diseases, that is diabetes, glaucoma, the awareness is still lacking at the rural areas. And so our efforts should be directed in such a way that we educate the general public in terms of these diseases. And similarly for the glaucoma as well, only about 7.8% knew what glaucoma was. Our study was highly significant when we compared the educational status with the awareness regarding the diabetes, regarding the special equipment that we need to diagnose the condition, and also regarding the treatment of such diseases. The similar results were also obtained when we considered the glaucoma, and this is a study survey that shows the acceptability of the rural health patients regarding the acceptability of the teleophthalmology services. And the one important factor which prevents patients from coming to the tertiary care center is the distance. And so that has to be addressed, and with the help of just addition of a single tool such as the fundus on phone or the digital fundoscope is what we refer to as. So we can actually bridge this gap and lead to better improvement of the rural eye patients. And so in our study, we saw that the diabetic retinopathy, the prevalence of diabetic retinopathy among the diabetic population was 11.9%, and combined diabetic and glaucoma accounted about 2.2%. So when I say that this study is very significant in terms of, so we need to turn this moment to movement, which needs awareness at the grassroots level in the community about the vision-threatening diseases, because one step towards saving vision, I don't think anybody of us should step back from that, because vision is highly important for any one of you, for me, and for everybody. And the primary eye care itself is an urgent need of this recognition and formal adoption by the profession, implicating effective sensitization of the fraternity in this regard. So DBCS, it focuses on screening for diseases like cataract, glaucoma. However, having said that, even the diabetic retinopathy, hypertensive retinopathy, glaucoma, and age-related macular degeneration changes need to be addressed and managed at first hand, and that can be just bridged using the teleophthalmology as well as the fundus on phone, also referred to as the digital fundoscopy, and that would serve the purpose of this community ophthalmology. So thank you one and all.
Dr. Rao,
Yes.
in your study, you are using this equipment. Can you preserve the document?
Yes, ma'am. We have all the documents, all the questionnaires of 1209 patients with us.
No. The fundus pictures.
The
and
fundus,
everything,
the fundus
so
photos.
that it can be seen afterwards.
Yes, ma'am. So what we do is we screen the patients at the DBCS camp, and we take the fundus photos on the digital fundoscope, and the results are analyzed with the help of the questionnaire. Everything is noted down in the Department of Ophthalmology at our
Only you
institute.
don't need patient to move.
Sorry,
But
ma'am?
you don't need patient to move.
Yes,
to
ma'am. So that's the thing, because distance
Because
is one of the...
teleophthalmology,
Yes, ma'am.
we are having a mobile setup.
Yes,
we are
ma'am.
keeping the patient here and the consultant seeing at the main.
At the main hospital, the
So
tertiary
that
care.
is the actual teleophthalmology.
Yes, ma'am.
In this only you are documenting.
In this, we are documenting the questionnaire. At the same time, we are screening the patient using the
Who is
digital
documenting
fundoscope.
your resident?
The resident doctor who goes to the DBCS camp, we hand over the questionnaire to those residents, and on a daily basis, wherever the DBCS campsite is, we screen the patients, ma'am. And I would say one thing, that a lot of people say AI in ophthalmology is artificial intelligence in ophthalmology, but I would put it across saying it is an augmented intelligence. Instead of artificial intelligence, I think we should refer it to as the augmented intelligence, which helps us. That is, there is a role of the ophthalmologist. At the same time, this is just augmenting the knowledge.
Then you are keeping the track to the patient also.
Yes, ma'am.
Because
We
if
are
the
keeping a track. Yes,
record
ma'am.
is there, patient is missing.
Yes,
Then it
ma'am.
will be useless.
No, ma'am. We keep a track of the patient. At the same time, the patient is also registered at the PHC level.
There, their campsite. You
Yes,
will be
ma'am.
having few doctors there also, those who
yes,
can convey the things there.
Yes, ma'am. So the medical officer usually keeps a track of these patients. However, at the PHC level, again, the eye care services really need to be improved, because they do not have an ophthalmologist at that setup. So I think teleophthalmology has to be considered significant enough in preventing those diseases. Thank you so much.
Nice study. Whether AI was used in analysis of
No,
these
ma'am.
pictures, not in this study.
For a few patients, yes, we did try, but mostly it is the ophthalmology residents who look at the picture and then we give the diagnosis.
So whether it was being seen by some consultants
Yes,
also?
yes, ma'am.
Yeah.
Under the guidance of Dr. Tanuja GP, she's a consultant ophthalmology at ophthalmologist at Ramaya Medical Institute.
Okay, thank you.
Thank you so much.
I have been the program director of National Program of I was National Program Control of Blind.
Yes.
We have the primary care and CMC and all that.
Yes, sir.
You are sending residents because you have got a medical college.
Yes,
But
sir.
by and large in country, it's very difficult to convince the secretaries and IAS and joint secretaries. Ministers, of course, don't know anything at all about
Yes, sir.
these subjects.
I think
So, you know, it's a very good idea that we can screen the fundus of
Yes,
these
sir.
persons at the district level or the, not primary health center, at least community health center.
correct, sir.
But you know, we are not getting doctors for community health centers, we are not getting doctors for primary health centers.
Yes, sir.
So, idea is very, very good.
Thank
But
you,
we
sir.
are far from
Yes, sir.
situation
It
which
still
we
has to be emphasized.
need-
It still
we
has
need
to
in this
come into
country.
the
The
picture.
government has to do it.
Yes, sir.
And government doesn't spend money on the health.
With the help of the government and our association,
Because
I
आपके
think we
medical
should.
college contribute कर रहे हैं so
Yes,
much of that. But
yes,
everywhere there is no medical college. No?
Correct, sir.
So it has to be government schemes.
Yes, sir.
So we are not doing because we are not putting enough money or enough people to do this. Otherwise, doctors at tertiary level will diagnose and advise.
Correct,
that,
sir.
Come along, we will operate you or we will do whatever.
Yes, sir.
Very good idea.
Thank you so much, sir. Thank you, ma'am.
Is Dr. Piyush Jain there? Any of the missing speakers are there? Dr. Siddharth Mishra, Dr. Ananya, Dr. Dinesh Verma. Then we'll move on to the keynote address by Dr. Rakhi. Is she there? She was here some time back. Okay, then we'll wait for her afterwards. Dr. Saroj Gupta is there? Yeah. Dr. Saroj Gupta will be presenting on protective behavior of time spent outdoors on myopia progression in children, a longitudinal study.
Very good afternoon to all. So I'll be presenting my study, Protective Behavior of Time Spent Outdoors on Myopia Progression in Children. It was a longitudinal study. So we know that myopia has emerged as a significant public health problem across the globe because there has been a rapid increase in the prevalence of childhood myopia over the past few decades. And we know that there are genetic factors which play a significant role in myopia onset and progression, but there are some environmental factors also which are associated with lifestyle which may have impact on myopia. And there is a positive longitudinal studies in the literature to ascertain the effect of environmental factors on myopia progression. So we have studied environmental factors on myopia onset and progression. So the study was done to determine the influence of time spent on outdoors in daylight by children on myopia progression, and patients were followed prospectively longitudinally. So it was a hospital-based longitudinal observational study done over a period of 2 years at a tertiary eye care center. And we included children like 6 to 14 years presenting with decreased vision in the OPD, or children with myopia of -0.5 or worse. And we excluded patients with refractive error other than myopia, with family history of myopia, or having anterior posterior segment disorders. We excluded them. So total 580 children were enrolled for the study initially. All children underwent cycloplegic refraction and glasses were prescribed. The spherical equivalent was calculated for all the children. And these children were followed every 6 months for 18 months. And at every visit, 6 months, cycloplegic refraction was done and spherical equivalent was calculated. Parents were asked to record the time spent in outdoor activity in daylight of their child in hours per day at school and at home during weekdays, weekends, and separately on a calendar provided to them at the start of the study. And they were asked to bring this record of activity at every follow-up in the hospital. Time spent outdoor activity in daylight was defined as playing on the ground during a break period in the school, or playing outdoor sports, riding a bicycle, running, playing in park, or even sitting in daylight was considered as a time spent outdoors. So time spent in outdoor activity per day was calculated every visit by dividing the total hours of outdoor activity in a week by 7. And these children was divided into 4 age groups. This is the methods which we use for statistical analysis of all the patients. A total of 495 participants completed 3 follow-up visits during the study period. So we include only those participants. And this table shows the descriptive profile of all the participants along with their spherical equivalent and outdoor activity in the hours across the 4 visits. It showed at baseline activity what was the score and what was the score at the 3 follow-up visits, these myopia as well as the hours of outdoor activity. And the inter and intra-individual association between the spherical equivalent and time spent outdoor in hours for 3 visits was determined by repeated measure correlation. And this repeated measure correlation was calculated as 0.26 minus 0.26, and we showed a statistically significant negative directional relationship between the outdoor activity and the myopia progression. And this is a chart which shows a repeat measure correlation graph, and this chart shows that there was an inverse relationship between the outdoor activity and the time spent, outdoor activity in the myopia progression, and this dashed line in the center represents the overall negative correlation between the outdoor activity and the myopia progression. Then we calculate the magnitude of relationship between the two parameters by mixed effect model method, and this estimated the effect of per unit time spent outdoors to change in spherical equivalent in subsequent visits after adjusting for baseline activity and their age category. And we found that each hour increase in outdoor activity per day, means every extra hour spent outdoors, had a negative effect on change in spherical equivalent by 0.6 diopters on a subsequent visit as compared to last visit. Now this 0.6 diopter change may not be clinically significant, but statistically it was found to be very significant. So our study findings are closely in line with Sydney myopia study, which suggests a predictive role of time spent outdoor activity in myopia in 12-year-old children. It was a cross-sectional study. Then North India myopia study was conducted on prevalence of myopia with significantly less in children who were playing more than 2 hours outdoor in day. Another study by Sherwin et al. Indicated 2% reduced odds of myopia for each additional hour spent outdoor weeks. But all these studies and other studies in literature are either cross-sectional or they're randomized studies. So the mechanism underlying a protective effect of outdoor activity and light exposure remains unclear, but there are studies in literature which shows that release of myopia from the retina on exposure to daylight, and this increased level inhibits the elongation of the eyeball. That may be the mechanism of the reduced myopia progression in children who are spending more time on outdoor activity. Our study has multiple strengths. Like this study had minimal recall bias, because other studies which are done, they were question-based studies. Question were asked to the parents how many hours child is spending, but here we had documented, given a chart to the parents to record the activity of the break period in the school and at the home also. So those recall biases were minimum. It was longitudinal study, follow-up study, where a causal relationship can be established between the outdoor activity and the progression myopia, where other studies are cross-sectional or randomized control trials. We have a large sample size of 580 children. Limitation is that it is institutional in nature, so the results cannot be finding being exploited to the population. So to conclude, increased hour of time is spent on outdoor activity at home and school may be a simple strategy to prevent onset and progression of myopia in school. And to our knowledge, this is the first hospital-based longitudinal study which was done in cohort of children presenting to tertiary care center. We have published this also in AIOCMT, and implications that we can ask the children to spend more time in the outdoor, and school, this can be added to the curriculum of this school to spend more on the break periods when the children go to outdoor in the daylight to spend activity, more time in daylight, because myopia is becoming epidemic in India and across the globe also. The incidence is increasing in India also, around 13% studies show. So this can be an additional therapy besides the low-dose atropine and other therapies which are going on to prevent the myopia progression. Thank you.
This is a nice study, because till now we were seeing the more they see the mobile, more they do the close activities, they increase the myopia.
Screen time is more in children.
So this is the positive study. Yeah. Second thing, have you asked of those children about the study period? How much they are studying?
School we have calculated how many hours they are studying in the school. And
because with the study reading, these outdoor activities should be calculated.
Yes. So we have got the indoor time in the school was fixed for all the children.
And from 6 to 14 years you have done?
Yes, madam.
So this will be overburdened, 14 years one will be overburdened by the studies.
Yes.
So is there any change?
But the school myopia usually occurs, madam, in this school children. That's why we have taken this sample size.
How did you adjust for the confounders? Because like ma'am said, near vision activities, then
Madam, the
parent-
near work during the school period was fixed for all the children because they have almost same curriculum. So we didn't take that into consideration.
like parental myopia, parental
That we
education, all
excluded by
those
excluding
risk
the
factors.
families. We excluded parental myopia. No? We
Okay.
excluded patients who had children who had myopia in the family. So genetic factor we excluded. So we took only environmental factors into consideration,
Okay.
the lifestyle.
What is the recommendation per week of outdoor activity?
2 hours
are-
per day is the recommendation, madam. 2 hours
And
per
per
day,
week?
1 hour like in school if they have, and 1 hour at the home, and daylight, not in the evening hours, because the daylight has the effect of increasing dopamine. So 2 hours is recommendation of the many studies. So at least 2 hours per day, child should spend outdoors in any of the activity, and that will help in reducing the myopia progression, besides the other measures which are being taken to reduce the myopia onset and progression, like atropine study and other atropine therapy and other studies are there.
It has been seen that 11 hours per week also is a protective
2 hours
thing.
per week, yeah.
11 hours per
Yeah,
week.
per week is enough.
And are you aware of any objective methods of measurement of the outdoor light?
Yes, there are devices which are fitted into the spectacles, which measure the amount of light which is child is exposed to. So their objective measurements are there. There are studies which are measuring with the spectacles, some device in the
Yeah.
spectacles.
Thank you.
Hygiene is very important.
Yes, yes. Yeah.
You know that in America they have banned the
Screen.
mobile for the
Yeah, for the children, they have banned at particular age, the children are not allowed to use.
mobile not only does the myopia progression, that mobile and bending of the head
The posture-related problems.
increases the length of the eye bar, and dryness is one feature which is coming
Because of
problem
the-
in children also.
Because of less blink rate
Because
and
of mobile.
yes. So COVID time it was very high.
When they look at the screen with the TV or anything, they blink much less.
Yes.
Than we all do.
And there are studies which show before COVID and after COVID times.
Computer is also a problem.
There are studies.
They were not using.
No, ma'am. And there are studies before and after COVID times. They found COVID times they had all homework on the mouse, so there was an increase in the myopia after COVID times. Thank you so much.
Dr. Ipshita Das. She's there. Dr. Ipshita will be presenting on a study on clinical presentation of patients with low vision and effectiveness of rehabilitation. You can start.
Good afternoon, everyone. I will present a study on clinical presentations of patients with low vision and effectiveness of rehabilitation. Informed consent was taken from all the patients. There was no conflict of interest and no financial support. The low vision essentially refers to a level of vision that prevents a person from performing customary visual activities such as reading, writing, orientation and mobility, etc., even with standard or conventional optical correction. Few studies have shown that the prevalence of low vision is up to 60% among the elderly population. Such patients may be benefited by the significant residual usable vision with the help of low vision aids for day-to-day activities. A low vision aid is conventionally refers to a device that improves or enhances the residual vision by magnifying the image of the object at the retinal level or by modifying the environmental factors. The aims of our study were to study the common etiological conditions causing the low vision in patients, to study the demographic factors in patients with low vision, to study different best suitable low vision aids advised and their compliance rate, and to study the improvement in the quality of life of the low vision patients after using the low vision aids. This hospital-based observational prospective study was done in a tertiary care hospital in northeast part of the India in 1 year duration. All patients with BCVA less than 6/18 in the better eye, patients above 10 years to 70 years of age and stable ocular condition were included in the study. Patients below 10 years of age and above 70 years of age, patients with acute or progressive ocular disease not willing to use any LVA and differently abled people are excluded from our study. Patients with BCVA less than 6/18 in better eye were considered as having low vision. 80 such low vision patients were thoroughly evaluated regarding the causes of the low vision and were given counseling and trial for different low vision aids. The best suitable low vision aid which had been accepted by the patient was advised. Each patient, whoever was advised low vision aids, were asked to follow up after 3 months. Patient's response was noted regarding quality of life before and after using the low vision aid and purpose of low vision aid use by a questionnaire. The quality of life was assessed by the level of difficulty in performing these 7 visual tasks. Each difficulty level was allotted score as extreme difficulty as 1, moderate difficulty as 2, mild difficulty as 3, no difficulty as 4, and stop tasks due to poor vision is 0. So the results shows the age distribution. The maximum number of patients were in the age group of 20 to 29 years of age and the mean age was 36.6 years.
Mostly the patients were male and mostly from rural areas. Among different etiologies, the most common etiology was ARMD followed by amblyopia, and the other causes were hereditary dystrophies, maculopathies, chorioretinal diseases, optic atrophy, nystagmus, and other causes. These are the BCVA for distance in the better eye on presentation. It was 6/18 to 6/60, which has the mostly the patients, most number of patients, and this is the for near. Most patients were in the group of N8 to N24. Out of 80 patients with low vision, 58 patients accepted the low vision aids, and therefore the best suitable LVOS was advised. However, only 40 patients showed the compliance, and they came for follow-up. So these are the different low vision aid advised. Among that, magnifying spectacle was the most commonly advised low vision aid, and the overall compliance rate was 68.96%. The compliance was highest for magnifying spectacle, followed by linear magnification. It was least for telescope. These are the purpose of LVA used, which was reported by the patient when they came for follow-up. So for reading, the reading related task was the most common purpose by the patient. The quality of the live assessment was done by depending on this visual task. So the post LVA mean score and the pre LVA mean score was compared. This shows a statistically significant improvement in the quality of life after using the low vision aid. This hospital-based prospective study aimed to identify the common etiological conditions of the low vision, demographic pattern, and the acceptance and effectiveness of the low vision aid. Our study found that the age-related macular degeneration was the most common cause of the low vision, followed by amblyopia. These findings are consistent with the study by Khan et al. Identifying the retinal disease as the predominant cause of the low vision. Pattern of advice of different LVAs were similar by studies by Khan et al. And Kim et al. Low vision rehabilitation is associated with the increase in functional status and improved vision. These positive changes are associated with personal and social benefits, especially increased autonomy and enhanced quality of life. As an individual becomes more independent and able to better perform routine daily activities, the severity of depression also decreases. These are my references. Thank you.
Dr. Das, it is a good presentation, but one thing is there. Can you tell me what was the problem with the vision when it was 6/18?
Actually, when it is like such a cutoff, the dependency increases.
No. What was the diagnosis of those patients? What disease they had? Mostly the patients with 6/18.
Yeah, there are different in the mostly there are different causes. Like some can be treatable, some can be the vision can be it can be better with refractive correction or any surgical methods. But
yes, I want to tell you this thing. If vision is 6/18, it is better to treat the primary problem in place of directly going to the low vision aid. Because by the meaning of low vision aid, they will be more depressed. If they are having a refractive error, if they are having ARMD, should see it.
Ma'am, actually we have prescribed low vision aid when we have tried all the methods, like routine methods, spectacle.
But you have not mentioned that it is not improved with the
with the best corrected visual acuity 6/18, after correction with the spectacle or any surgical method, whatever can be done, when with all the efforts we cannot improve the vision, then only we selected or counsel the patient for low vision aid.
As per the requirement.
Yes, ma'am. As per
the profession or the
occupation. Routine. Yes, ma'am. Whether they need the distance mode or near mode, according to that. And
thank you. Nice.
Thank you.
Now I would invite Dr. Aki for a keynote address, The Eye and Tick-Borne Diseases, a study from South India.
So good morning everyone, Dr. Aki, and I'll be talking on a paper, the tick and eye manifestation, a study from South India. So the objective was to study the ocular manifestations and complications following tick bite. So we analyzed all the cases that presented to us with tick bite during the monsoon seasons in South India. All of these patients were residents of Kerala. We did a detailed ocular evaluation, fundus evaluation, followed up all of these patients at very frequent intervals to monitor for the systemic manifestation. A liaison with a local physician and a microbiologist was created in order to refer, treat, and follow up all the included patients. So the primary outcome was to study the ocular manifestation. Secondary outcome was to find the chances of development of systemic manifestation and to find the efficacy of prophylactic antibiotics. So we had 23 eyes of 23 patients, unilateral. Higher incidence was in the monsoon season. BCVA ranged from 20/20 to 20/100. So out of this, the period of presentation of the tick bite was nearly 5 days. And tick was present in situ in around 13 eyes. It was live in 10 cases. Associated fever was there in 7 cases. Mean period of development of fever after the tick bite was 7 days. Most common symptom was eyelid pain. Sign was eyelid edema. Self-removal of tick was attempted by 10 patients. Non-granulomatous anterior uveitis was seen in 5 cases. Mean period of development of uveitis after the tick bite was 11 days. One case presented as a conjunctival nodule with a dead tick had severe uveitis. So prophylactic antibiotic prophylaxis with tab doxycycline was taken in 16 eyes because, as you all know, Kerala is very endemic for all sort of tick bite in manifestations. So 5 eyes presented later with NJU and 4 cases with retinal involvement. 1 case of a 78-year-old male present with NGAU, vitritis, and macular edema. Actually, in this patient, there was parts of the head recovered from the eyelid nodule with surrounding ulceration, and that is why he had a severe manifestation. So these were the pictures of few of the patients who were presented to us. So we tried to identify the species. It was possible only in 11 cases, and the most common species was Ixodes. But what we found that whenever it was the dog tick, that is the dermacenter type, it almost always led to fever, even if not given prophylactic treatment, antibiotic treatment. 4 presented with retinal findings. One of this that presented with retinal finding still has a residual lid edema, and the eye pain was accentuated by ocular movements. History of myalgia and mild fever 2 days prior to the onset of defective vision. These patients were sent to the physician and were started on tab doxycycline along with rifampicin and also low-dose steroids for 4 weeks. Steroids were very slowly tapered. So ticks, as we all know, ectoparasite can cause various life-threatening diseases like Lyme disease, tularemia, rickettsia, Q fever. Mostly they are reported from US and Europe, but it is not uncommon here. It is rather underreported. Clinical awareness is very much needed. It is easily overlooked. Serological testing is limited in these cases. So why do they prefer the lids? So they habitually enroots lids because there is this meibomian gland orifices, and also they present like a mass that mimic the appearance of a hemangioma, nevus or epidermal cyst, and it can be easily missed. And because the lid area, the tick has a fondness for this warm, moist environment. And the possibility that ticks can easily travel through these eyelashes, and then it can masquerade itself within this lid, black pigmented area of the lid is another reason why they prefer the lids. So how it gets its bloody meals. So what the tick does is, once it bites, it inserts its hypostome and it secretes certain cementing materials into the skin. And this material has got certain anticoagulants, immunosuppressives, and anti-inflammatory substances which help it to get a effortless blood meal without the host noticing. So there can be various manifestations. Almost all manifestations can be possible after a tick bite. So how to remove? The best method to remove is to do either an en bloc excision or to remove with a blunt, medium-tipped angle forceps. People have used many other methods like petroleum jelly, gasoline, betadine, but actually none of this should be done because if we are going to use sharp forceps, so if we are going to twist the head, it is going to emit that body materials, which is actually potentially infectious, and that can lead to zoonosis, specifically Lyme's disease. So to conclude, most common site of tick bite was near the lashes. Commonest symptoms was eyelid pain with edema. Incidence of systemic manifestation was 7 in our case, and mostly with dog tick bite. Posterior segment involvement was also there. So, as in our population, it is advisable to start prophylactic tab doxycycline in all the cases, since the chance of development of complications is still unpredictable. Thank you.
Nice presentation, Dr. Aki. Thank you. Any other presentation?
Very interesting topic.
Demodex मिला था मेरे को? Demodex. Lips पे चिपटा होता है वो just like you don't even know, you feel like it is something from my center or something, and you examine it is a 6 feet, like 55 feet or getting and all that, and then 6 centimeters. So उसको हम कहते हैं बेबी शैम्पू से जॉनसन बेबी शैम्पू को 110 करके डाइल्यूट उससे ये कर दें तो उससे मर जाता है, ठीक हो जाता है. But Demodex को मिस कर, we miss it so many times because we just show it white spots under the lashes, so we don't see them properly. But Demodex is now indicated in so many MGD cases, in at least studies of Europe and America. And now in my clinic also I see that once I see the eyelashes, something white. So baby shampoo का सिर्फ eye David Johnson baby shampoo was in that and it was so Demodex मिले ना मिले वो तो मिलता ही नहीं कहीं वो देखिएगा भाई इतना माइक्रोस्कोप ही नहीं हमारे पास Demodex कभी दिख जाए तो लगेगा